Hello, everyone. My name is Elizabeth Yim. I'm a first-year medical student here at the CUNY School of Medicine. Yesterday, Dr. Chamberlain talked about how short people shouldn't step behind a podium without a step stool. So can everyone see me, or should I step out? Okay, good. So I'm kind of an outlier among my peers who went to Tanzania in that my project focused on cervical rather than breast cancer. So first of all, I'd like to acknowledge my school, the CUNY School of Medicine, because they provided me with a MacLipkin Broader Horizons Fellowship, which funded my study. And I was able to go to Tanzania and conduct research to try to understand causes of loss to follow-up among women suspected of cervical lesions in Tanzania. So first, what is cervical cancer? It is cancer of the cervix caused mostly by human papillomavirus, or HPV for short. Who's at risk? Most sexually active individuals. Globally, it's the third most common carcinoma after breast and colorectal, and most cases of cervical cancer can be found in developing countries, and most of the cases found in developing countries are usually found in their late stages. So I must admit, before going to Tanzania, I had no idea where it was. I just knew that it was somewhere in Africa. So you can see in this world map over here, the darker the color is, the higher the prevalence rate of cervical cancer, and the highest rates can be found in East Africa, where I learned Tanzania is. In Tanzania, the leading cause of cancer is cervical cancer, and the leading cause of death from cancer is also cervical cancer. And in the world, it has the 6th highest age standardized rates of cervical cancer. So I knew that this was an issue that I wanted to tackle. Specifically, I worked in Dar es Salaam in Tanzania. So I provided a map because I know not everyone may know where Tanzania is. So the World Health Organization established a referral program between Ocean Road Cancer Institute and 2 local health centers. So Ocean Road Cancer Institute currently is the only facility of its kind in Tanzania that has chemotherapy and radiotherapy capabilities, and is also seen as the gold standard for screening for cervical cancer in Tanzania. It has more than one method of screening. So in America and other developed countries, we usually do screening via pap smears, but that requires taking a sample, sending it to a lab. It requires cytologists in a couple days that the samples will take to get analyzed. And people in developing countries don't really have that time or money or sometimes trained cytologists. So instead they use visual inspection with acetic acid, or VIA for short. Ocean Road also has another method, visual inspection with Lugol's iodine, that's sometimes used to confirm the results. However, centers like Tamiki Referral Hospital and Magamini Health Center only have VIA capabilities. Also, if small lesions are seen, they treat them using cryotherapy and polyp removal. So Ocean Road has those capabilities, but Magamini does not. Tamiki has those capabilities as well, but Ocean Road is still seen as the standard for care and screening. So this is what the referral process looks like. This is Nurse Raya from the Tamiki Referral Hospital. She is counseling a patient here who she has just seen signs of suspected cervical cancer. So she's telling her that she has to go to Ocean Road for further screening and potential treatment. This is what the letter looks like on the left-hand side, and this is what the screening clinic looks like. She's also filling out the form, and then later beneath the form you can see the logbook, which will fill out the information about the results. And ultimately, those logbooks were what I used for my study. So my project was inspired by the work of another CEIF student who in 2017 published a paper. She wanted to understand the rates of false positives among screening for women who went to Tamiki and Magamini and then were referred to Ocean Road. And she found that 44% of women referred to Ocean Road from Magamini did not go for follow-up, and 64% from Tamiki did not go for follow-up. So my aim is to understand causes of loss to follow-up among these women. And then secondary to that, I also wanted to assess levels of knowledge about screening guidelines, screening practices, and about cervical cancer among these women. I also wanted to ask these women what the best thing to do would be, how we can best help them receive these services, and also I wanted to design a tracking system for follow-up. Currently, there's no way to send the nurses at Ocean Road information about these women. They don't get notified if these women are supposed to be coming for further screening. And also the nurses at Tamiki and Magamini, sometimes they contact the women that they refer, but it's mostly due to personal interest. There's not a regular system of checking all the women who are referred. So because my work builds upon the work of other students, I had a number of different sources to my utilization. So I used Anne's data from February 2015 to May 2016. Taylor Rogers was a student who went to Tanzania last summer and collected data from May 2016 to December 2016. And when I went, I collected data from January 2017 to 2018. So the materials that I used were the logbooks from Tamiki and Magamini to pull the names and phone numbers of the women who should have been referred. And then I compared them to the logbooks at Ocean Road to see if they came within 3 months of referral. The only period of time in which I'm missing information is from February 2015 to May 2016 among the women who did follow up, because I'm missing Anne's data and the Ocean Road logbooks are missing. But aside from that, I have all the data about the women who did and did not come from these 2 clinics. So 5 attempts were made to call these women at varying times throughout the week and throughout the day. And I had the help of Dr. Matthew Nindi and Nurse Felista Masawi, who helped me interview these women over the phone and then translated the questionnaires. So this is Ocean Road, and these are the physical logbooks that I was entering into my Excel sheet. That's a picture of the records in the screening clinic at Ocean Road. And this is Nurse Felista and Dr. Matthew. So of the 451 women referred to Ocean Road from Magamini, I interviewed 201 of them. So there were a number of missing phone numbers in both logbooks. Some women were unable to complete the interview because they were hard of hearing and thus could not communicate effectively over the phone. Some of the numbers were blocked or barred or with someone else when I called them. So in Tanzania, if you don't use your phone SIM card within 3 months or so, they're typically barred or transferred to another patron. So that led to some women that I was not able to contact. And there are currently 70 interviews that are still pending, so I've tried to call these women at least 3 to 4 times, but I haven't completed 5 attempts yet. Of the 273 women referred from Tamiki, I interviewed 90 of them. The reasons why I couldn't contact the other women are listed as shown here, and they're similar to the reasons for Magamini. So of the 291 women that I interviewed, 108 of them, around 37%, did not follow up for care. And if broken up by clinic, you can see that 36% of those referred from Magamini and 39% of those from Tamiki did not follow up for care. I asked them basic demographic questions, and for statuses such as age, highest level of education attained, occupation, marital status, insurance status, and parity, there didn't seem to be glaring differences that emerged. But what did start to emerge was when I asked about the length of time that it took from their place of residence to the local health clinic. In green are the women who came, and in red are the women who did not. So it seems that more of the women who came lived closer to the health clinics than those who did not. I also asked the women why they first came to Tamiki or Magamini, and the number one cause for both groups was that they were experiencing symptoms. I also broke down the symptoms below, and as you can see here, the number one reason or the number one symptom was lower abdominal pain, which is worrying because typically lower abdominal pain is a sign of the later stages of cervical cancer. Also, some women said that they came for other services, so that can be like receiving treatment for malaria or coming for breast cancer screening, basically any reason other than solely for cervical cancer screening. Some women were also advised to screen, so if they found out that they were HIV positive, typically nurses will refer them to screening because you have a higher chance of having cervical cancer because of your greater chance of infection. Some women said that they heard announcements over the radio or saw posters for cervical screening, and very few of them said that they came for a routine screening. So they've been screened before for cervical cancer. I asked women about their levels of knowledge about symptoms, prevention methods, and treatment for cervical cancer, and the largest gap in knowledge was among women who didn't know about prevention methods. Around half of them said that they had no knowledge of it, no knowledge of symptoms. 80 to 90% said they had no knowledge about prevention, and then around half said they had no knowledge of treatment. So these categories were defined as no knowledge being that they could name no symptoms, prevention methods, or treatments, little knowledge being that they could name one, and some knowledge being that they could name two or more. Bigger differences started to emerge when I asked about if they knew anyone who's been screened for cervical cancer, diagnosed with cervical cancer, or died from cervical cancer. And in blue are women who did follow up. So you can see that more women who did follow up had some sort of familiarity with someone who's been afflicted with cervical cancer. And then when I asked how severe they thought cervical cancer was, the different choices were no knowledge, like they don't know, not severe, a little severe, severe, or very severe. And the number one response for women who did follow up was severe, while the number one response among women who did not follow up was very severe. So this could indicate that among women who did not follow up, there might be a higher level of fear about mortality related to cervical cancer, which might be why they avoid seeking care at Ocean Road. Among women who did follow up, who noted that it was severe rather than very severe, that could potentially be because they have familiarity with women who've been affected by cervical cancer. I asked the women what the nurses at Tamiki and Magomeni told them about what they saw or what the future steps would be, and 96.7% of the women who did come said that they received a referral letter to Ocean Road, while among the women who did not come, 50.9% said that they were given a referral letter to Ocean Road. So that's a big difference among these two groups about the clarity of directions to go to Ocean Road. And in blue, I've highlighted a number of reasons that indicate noncompliance to the WHO referral method. So some women said that they were not told to go to Ocean Road, or that they were told to come back to Tamiki or Magomeni for further screening, or that they were referred elsewhere, like Muhimbili National Hospital. I also asked the women what they think are the outcomes of cervical cancer, and these are not all the reasons, but these are the top 3 responses that I received. And about equal amounts said that if untreated, you will die from cervical cancer, or that your symptoms will get worse. Almost twice as many women who did follow up knew that if treated early, it's better, which might indicate why they came within 3 months of referral compared to the women who did not. Surprisingly, more women said that they don't know about what would happen if you get a diagnosis of cervical cancer among women who did follow up. So that might indicate that there's 2 groups of women who did follow up, the group that knows that the earlier it's treated, the better, and also the group that didn't know and came for care anyway. So among the reasons for loss to follow-up, the number one reason was error in the WHO referral process, or when I say error, I mean a non-compliance to it. The second most common reason was an inability to pay for a biopsy. So in Tanzania, financial ability is not as much of an issue because screening and treatment is free. The only thing that patients have to pay for is biopsies, but you do have to receive a biopsy before receiving treatment, so for a few women it is an impedance. It's about 80,000 shillings, which is around $35, but that can be a huge barrier for some women in Tanzania. There's also a culture of compliance in Tanzania. It's considered culturally unacceptable to refuse care, so that's not as big of a reason to why women did not come for follow-up as I had expected. Also, work and family life did not really seem to be big factors either, because most of these women are housewives, so their work schedule will not affect their ability to come. I asked women how Ocean Road and the government can help, because not only do I want to understand the barriers, I want to know from them what we can best do to reduce these rates. So most of them said that they would like to have education provided to them. When given other options such as having a community health worker guide them along the way, or having text message reminders or phone call reminders for their appointments, these did not seem to be as effective, at least to them. And I think this might go back to the fact that there's a culture of compliance. So once they understand that they have an appointment, they will most likely make the appointment, and these reminders are not as necessary. And the idea of community health workers and peer navigators is a newer concept, so perhaps they don't think that this will be as effective as just general health education. I also asked who they like to receive this education from and where. So most of them said they'd like to receive it from a nurse and at a clinic. So this just goes to show that Ocean Road and other hospitals, like Tamiki Referral Hospital and Magomeni Health Center, the responsibility falls to us to provide this help. So you can see here Nurse Sharini from the Ocean Road Screening Clinic. Every morning at 8 a.m., different nurses from the clinic will provide education to women who come in for screening and also their family members. So another thing about Tanzania is that medical visits are a family affair. They usually come with their entire family or other members, their friends. So this provides an opportunity for further health education even among women who don't come specifically for screening. So because of these findings that started to emerge while I was conducting this study, I started another study with Flora, and I'm trying to understand among the women who come to Ocean Road for screening how much they know about screening guidelines, screening practices, and cervical cancer so that we can assess their levels of knowledge and the areas of need. What are some strengths and limitations of the study? This is a multi-year study from 2015 to 2018, so it covers a large range. It also builds upon a well-designed WHO study and referral system. Tamiki and Magamini make up most of the women referred from outside sources to Ocean Road, so this is a good place to start for assessing referral. And also this is an opportunity to remind or notify women about cervical cancer, because some of them told us that they were not told by their nurse to go to Ocean Road for screening. And according to the logbooks, there were some lesions that were seen or suspected cervical cancer, so potentially this is another opportunity to remind them to receive care. Some limitations were that since these interviews were done over the phone, some of the numbers were blocked or wrong numbers or missing phone numbers from the logbooks. And also sometimes it's hard for women to admit barriers to care. So my data, of course, relies on the responses of the patients, and so this could be a potential limitation. Future analysis includes continuing to contact the women that are still pending. I want to compare the rates of follow-up between women referred from 2015 and 2016 to 2017 and 2018 because this program was established in 2015. And since then, I've noticed a huge drop in the loss to follow-up, especially among women from Tamiki. So if I could compare those rates, maybe I can understand why there's been a big improvement at Tamiki and then apply those changes at Magamini and at other hospitals. And also, I'd like to implement a tracking system within this referral process and then track the effectiveness of that. I'd also like to assess the results of screening and stages of cervical cancer among women who do follow up, and also to compare the loss to follow-up rates between women referred from Ocean Road to another part of Ocean Road to the women referred from outside hospitals. So learning experiences. This was my first time as a principal investigator of my own research project, so I learned how to design a study from start to finish, and also how to design a questionnaire that was both culturally competent and also effective in eliciting the responses I was interested in. I also learned how to work with a research team, so my on-site mentor, Dr. Khadija Masami, is a native of Tanzania, and she's also spent time in America going to school and receiving her degree here. So she taught me about how to navigate and walk the line between the two work cultures, and she provided a lot of direction in connecting me to nurses and my research assistants. I also learned a lot about problem solving because these records are all paper records. There are a number of missing records, different sources that I had to compile and analyze. I also learned a lot about the culture there in Tanzania, about how healthcare can be received differently from here in America. I also, like Damien and Kristen mentioned, got to go to different hospitals, and I experienced and learned about the different levels of healthcare provided, specifically Amana Hospital and Bagamoyo Hospital, which are two different hospitals. One is urban, one is rural, and I noticed the differences in its organization and management, and I noted areas of need. So for example, both of these places have surgery theaters, but no histopathologists on site. So they can perform biopsies, but not analyze them, and they have to send them to Muhimbili Hospital, which has the central pathology lab. So anytime that a patient is referred elsewhere, there's the potential for loss to follow-up. So that is a downfall and area of need for these two places. Also for Muhimbili National Hospital, that's where the medical school is, and I learned about their community medicine rotation class, where students are sent for up to 12 weeks to different areas of Tanzania and learn about how different levels of healthcare look like. They learn from district medical officers to learn about management of care, and also at the end they implement a proposal to better the community's health. Some strengths and limitations of Ocean Road, my colleagues have mentioned them already, so I won't go too much into them. I also conducted some interviews with nurses at Tumiki and Magamini as it started to emerge that the number one reason why women did not follow up was because of something that was systematic. And I learned that Tumiki has 2 regular screening clinic nurses with a lot of experience, training, and supervision. Whereas the nurses at Magamini, there seems to be a constant rotation of nurses who perform the screening, and most of them are new. Also, sometimes when they're overwhelmed, they admitted that they have medical students and nursing students perform the screening, so that could be a potential reason why there might be a loss of follow-up if they don't properly counsel the women about what the future steps are to take. So that is something that emerged from this study that I would hope to see addressed. Also, like Kristen mentioned, we also found time to have fun. So we went to Zanzibar one weekend and went to Faradani Park where there's a night market, and the cook let me try to flip Zanzibar pizza, so that was really fun. We got henna done, and Kristen and I found time to go to Mikumi National Park where we went on a safari. And what are my future career steps? I've been lucky enough to be awarded my school's Rudin Research Fellowship, so this year I'm going to be continuing working with Dr. Solomon and the Memorial Sloan Kettering Cancer Center to understand underutilization of screening clinics in Harlem, and I hope to apply what I've learned from serving the underserved community in Tanzania to the underserved community here in Harlem. And lastly, I'd like to acknowledge Dr. Solomon, the CUNY School of Medicine, the Mac Lipkin Broader Horizons Fellowship, my mentors, Dr. Masami, Dr. Musalagi, and Dr. Kesa from Ocean Road, my research assistants, and all the nurses at the screening clinic who helped me with my study. Thank you.
Could you really tell when a woman that you interviewed said she was not told to go to Ocean Road, or she was not given the referral letter, whether that reflected a failure to tell her and give the letter, or her recollection of something that was different from what actually occurred? How many of the women who said they weren't told to go to Ocean Road actually weren't told to go to Ocean Road, and how many were told but now recall that they weren't told?
So I was better able to assess that among the women referred from Tumiki because the 2 nurses at Tumiki had better log bookkeeping. So they would write, there's a column for referral and future steps, so they would write referral. So I think among the women referred from Tumiki who didn't go, I think it might be a lack of understanding about the direction, but that the direction was given, versus from Magamini where there was pretty sloppy bookkeeping. I felt that I wasn't able to really ascertain whether women were really told or not.
One of the things that was a great talk, so thank you.
You.
So they've all been great talks, so thank you. And your stature, your stature is great. You know, in the United States, one of the insights that people have had is to go do the education at places where people are at. So, for instance, African American education is going on in barbershops or in churches or in beauty salons. Asian education is going on in grocery stores, in Asian grocery stores and stuff like that. Is there any equivalent to gathering places that are trusted in Tanzania, like Asian grocery store, for instance?
Surprisingly, the number one response for women was that they'd like to receive this education at clinics because some of them said that there's still a level of stigma that's associated with cancer. And so some of them mentioned specifically that they would not want to learn about this in a community setting. They'd prefer clinics mostly. Or some even mentioned like schools, and because a lot of people in Tanzania are religious, potentially mosques and churches, but still the majority of responses was that they'd like to receive the information from who they trust, which are typically nurses and doctors in clinics.
Thank you, Liz. Great talk.
Thank you.
So you have a slide which said the distance of the patient from the local center.
Yes.
But do you know the people who have missed the follow-up? How far are they from the ORCI?
Sorry, could you repeat the last part?
So how far are the patients from the ORCI? So they missed the follow-up at the ORCI. So how far do they live from the ORCI?
Yes.
So you had a slide about local hospital distance from the local clinic, but not from the ORCI.
Right. So the reason why I asked the distance from their place of residence to the local health clinic was that for women who did not go to Ocean Road, they won't know how long it is from their place of residence to Ocean Road. So I chose to the local health clinic so that I could compare the data between the two groups.
Okay. So do you think ORCI has any kind of outreach program? So most of the hospitals in the rural areas, so what it can be due to as simple as transportation. So the people, patients can't afford, so they neglect it to the last, like, until it's severe, life-threatening. So that's what we have seen. So what we have is like, I'm giving experience of my previous experience in the India. So what we used to do is like, we used to go out to the patients. So even though we are based on the primary tertiary care hospital, every week or every 2 weeks in a month, we used to have an outreach. So we used to go to the rural areas. Then on the way back, we used to get patients to the hospital. So we used to give free transport to the patients. So that way they keep up the follow-up in the clinics. And they also used to have a free transport back to their place. So it used to be like twice a week or like once in 2 weeks, something like that. So they have a round trip free transportation.
Yeah, I think that's a great idea, especially because Ocean Road still is the only facility in Tanzania with these capabilities. There definitely should be more of these facilities and in different locations so that the women who are referred can go there. That's a good point.
To help you answer, so there was they actually had a service like that where they had like transportation, but it was like a home service where the doctor will go and then provide the services to the patients. But what happened was that as it was explained to us by the doctor at Muhimbili, it was like they kind of transferred the funding to something else. So that there was like an infrastructure for that prior to that. But I think they ended up like selling the cars and stuff like that. So they had to like focus more on the treatments and transfer the fundings to treatment services.
Thank you.